Mounigan, starting the afternoon session, and it's a delight to introduce Dr. Joseph Bonventry, who is the former division chief at the Brigham and a real giant in the pathophysiology of acute kidney injury. He discovered many different transcription factors and other links in the pathogenesis of AKI. Did a lot on biomarkers for AKI and started working on creating kidneys in a chip with renal organoids, and has had an incredibly distinguished career, including the Homer Smith Award at one of our last ASNs. So without further ado, I'm happy to introduce Joe to give this talk.
Thank you, David. It's a pleasure to talk about my favorite topic, acute kidney injury. Here are some of my disclosures. And basically the objectives of this 27 minutes or so will be to talk about the pathophysiology of ischemic and toxic acute kidney injury, and to talk about the implications of the pathophysiology for progression to chronic kidney disease and approaches to therapy. This topic is enormous, and we're going to be relatively superficial, but my goal is to really prepare you also for the rest of the afternoon, where there'll be additional discussions of cases and other things relating to AKI, but to have a general overview. So here I'm going to initially start with the definitions, and then the pathophysiology in basically talking about blood vessels, tubules, and inflammation. And then the repair process leading to, when it's maladaptive, leading to chronic kidney disease. And then finally, just touch on some therapeutic approaches motivated by pathobiology. I'm also going to talk a little bit about some recent clinical studies that relate to AKI and that are of significance to at least know about. So back in 2005, we published this paper coming out of the Brigham, basically defining the fact that small changes in serum creatinine were relevant. They increased the risk for mortality and morbidity. And up until this time, we had the term acute renal failure. And this study, and then another study from the Cleveland Clinic in postoperative patients that basically reproduced the same sort of story, led to the notion that we perhaps ought to change the definition and really take into account the fact that small changes in creatinine were relevant for patient outcomes. And so that led to a number of international groups coming together to talk about the definition. At the time, there were about 26 definitions of acute renal failure in the literature. And so after a few of these attempts and different definitions, this is the one that is generally the one used right now. It being defined by a change in serum creatinine by 0.3 milligrams per deciliter within 24 hours, or serum creatinine rising to greater than 1.5-fold from a reference value known or presumed to have occurred within 7 days, or urine output less than 0.5 milliliters per kilogram per hour for greater than 6 consecutive hours. So clearly you can see the definition is very much focused on serum creatinine and urine output. And there's different stages, and the higher the stage, the more severe the change in serum creatinine, or the more severe the reduction in urine output. So generally staged as stage 1, which is the milder form, still relevant for outcomes. More severe form, stage 2 or stage 3. Now, but there's still been a lot of progress, and we really don't have good therapies for acute kidney injury. And and the feeling is that those of us who were involved in the definition, we also recognize that acute kidney injury is not necessarily acute tubular interstitial injury. Because acute kidney injury, if it's defined by a change in creatinine, we all know that there can be changes in volume status that could result in a change in creatinine without necessarily injury per se. And so there's also been a look at whether or not we can have other biomarkers that could either replace serum creatinine or can define it a little bit more with more clarity using both serum creatinine, potentially volume, and these other markers. Creatinine is not a great marker for AKI. This is a standard list. I'm not going to go through them, but we all know that it can be altered by medications per se because of changing tubular handling. Creatinine is not completely only filtered. In fact, it's not freely filtered. It's mostly freely filtered, but it's then secreted. And the combination of the two basically is an estimate of GFR, but it's not great as a marker. And the other thing is that really by definition, with an elevated creatinine or lower urine output, that's really only the tip of the iceberg in terms of kidney dysfunction or injury. So you can have injury without a change in creatinine. You can have injury without a reduction in urine output. Another factor is that there's this concept of renal reserve. So that if you're talking about injury to the kidney, it really depends on what your underlying kidney status is. And if it's normal, if your kidney status is normal, then a reduction or an injury may not result in a change in creatinine because it'll basically, you have this renal reserve. With increasing damage or increasing chronic disease, then you will, in fact, then get to the point where tubular injury will be reflected by a change in creatinine out of the normal range. And here's another example. This is studies that we haven't published, but these were young 20-year-olds with testicular cancer, so starting out with very normal kidneys. And when one looked at creatinine after 5 treatments, 5 regimens of cisplatin, there was no change in serum creatinine. And yet with each regimen, there was an increase in these injury markers, in this case, KIM1, kidney injury molecule 1, or NAG, showing that there was clearly a response of the kidney, an injury response, but no change in creatinine. And so the current status of all of this, fast forwarding, the FDA has recently qualified these 6 biomarkers for kidney injury or nephrotoxicity, and currently are considering the qualification of these 6 biomarkers for clinical use with patients. The first qualification with drug studies with pharmaceutical companies and phase 1 studies. The qualification that they're examining right now will be applicable to a broader population of patients who are being treated under various conditions. Okay, and what about now moving to pathophysiology? I still think this is a reasonable way to look at the pathophysiology as when you're approaching a patient. Is it pre-renal, is it intrinsic renal, or post-renal? And there's some controversy about whether this is old-fashioned or whether we should do it a little differently, but I still think it's useful. And with the intrinsic renal can be related to glomerular causes, interstitial vascular causes, or tubular injury related to toxins or ischemia. And the mechanisms, the basic cellular mechanisms, relate to, at the level of the tubule, they relate to obstruction and epithelial injury. At the level of the vasculature, they relate to endothelial cell activation, leukocyte recruitment, and vascular injury. And the pathobiology depends on the location of where the injury is, tubular versus glomerular versus vascular, as a primary place, although most of the time it's more than one locale. The time, is it acute injury or chronic injury? And the mechanisms involve inflammation, mitochondrial damage, DNA damage. And then after the injury, the repair, the kidney goes through a repair process, which can be adaptive, resulting in a kidney that's not too different than the kidney was before the injury, or it can be maladaptive, ultimately resulting in chronic kidney disease and fibrosis. I think it's also important in terms of the pathobiology, and when we think about vasculature, we should recognize that there are many causes of acute kidney injury, including large volume changes, but also things like cyclosporin medications that are involved in small vessel changes that can result in local ischemia. And any vasculitic, TTP, malignant hypertension, scleroderma, to go through the whole list. And sepsis is another separate category, but it's generally felt that sepsis has an important vascular component to it also. And the other thing to remember in thinking about the sort of vasculature in the kidney and the relationships to the tubules, it's important to recognize that, contrary to what the textbooks generally say and depict as oversimplified figures, there isn't a one-to-one relationship between the glomerulus and the tubule. This is an example. This is a midcortical proximal convoluted tubule. You can see why it's called convoluted. And you can also see some glomeruli here in gray, but the glomeruli, this tubule is fed by vessels from at least 10 glomeruli. So if you have, for example, a vascular problem with this glomerulus, you're not only going to affect one tubule, you're going to affect a number of other tubules that the efferent vessels from this glomerulus perfuse. And the other thing about the vasculature is that in the outer medulla, the vasculature is particularly interesting in that this fuzzy zone, which is actually what the German pathologist called it, the fuzzy zone, of small, very tenuous vessels, perfuse the thin limbs, but also in the outer medulla, perfuse the S3 segment of the proximal tubule and the thick ascending limb. And in a setting in the medulla, there's a oxygen gradient going from cortex to the papilla tip. And so already there's some hypoxia. And if you compromise this blood flow, as frequently happens in sepsis and other things, then you can understand why, even though you don't have a reduction in total renal blood flow, you can have a compromise of the blood supply to these tubules. You can have sloughing of the epithelial cells, and you can have obstruction and dysfunction. And here's another thing: you can alter the glycocalyx of these vessels with ischemia, and that also results in increased binding of leukocytes and platelets, and ultimately can result in plugging of these small vessels. This is shown here in an example. This is a mouse kidney, whereby we've induced unilateral ischemia in this context, and looked at how long it took for perfusion to return to normal. And even though we removed the clamp after 25 minutes, it took 24 hours for the blood flow to return to close to normal, as reflected by the red staining of this tissue. And there's reason we have also data, and others have done this using this sort of ultrasound approach in humans to reflect the fact that this is likely going on in the outer medulla in humans. So with this compromise in the vasculature, then you can have an increased inflammatory response, abnormality in the blood vessels, binding of leukocytes, platelets, and then increase in the permeability of the vessels, with increased fluid entry into the interstitium. And here you can see there's abnormalities in the epithelium itself when compared to the normal here. But this increase in fluid can also cause obstruction and compromise of blood flow. And so in the context, I'm not going to go through all of this, but this is what we and others, many people study, the details of the injury signals in the glomerulus and in the tubules, but in particular here in the tubules, involving reactive oxygen species, changes in metabolism, DNA damage, mitochondrial injury, and induction of an inflammatory response, which again then results in infiltration of more inflammatory cells, more vascular damage, and more local ischemia. And this interstitial edema that can evolve can be very detrimental because, and that's recognized by intensivists more recently in many, many situations. Here's a list of which you have in your notes, so I'm not going to clearly go over this, but there's all sorts of things, myocardial edema, fluid overload in general in the acutely ill patient is problematic. And unfortunately, from a clinical perspective, many times you see a patient who's fluid overloaded, whose vasculature is compromised, and the all too often therapeutic approach is one to give too much in the way of fluids to enhance the perfusion, but that has an effect to actually reduce the local perfusion, in particular to the kidney, but other organs as well. Okay, and in this context of fluid management, here's a simple question. And according to the Surviving Sepsis Campaign guidelines, which type of fluid is recommended for additional resuscitation of patients with sepsis-induced hypoperfusion and AKI? I don't know. Okay. Sorry, I'm having trouble seeing it, but I think, yeah. So I think most people have answered the first one, and that's the correct answer. In fact, let's see. Okay, so the general principle, AKI oliguria is not an indication for fluid administration. Intravascular hypovolemia should be the only indication, intravascular. And the optimal fluid composition has not been defined, but essentially buffered solutions are recommended if the patient is at risk of AKI and they're not hypochloremic. 0.9% saline, normal saline, is recommended only for hypochloremic patients. And things like gelatin are to be avoided. Albumin does not provide a survival benefit, and starch should be avoided. Okay, and again, there's other aspects of the pathobiology of AKI in the context of having distal effects on the lungs and the kidney, or the other areas of the kidney that are not directly initially affected, but the heart and the lungs and the brain are also have effects at a distance of acute kidney injury. Okay, and what about then moving along here to the maladaptive repair? AKI can lead to CKD, and CKD predisposes to AKI. So you can have different sequences of events with injury, and here's some examples of GFR dropping, and then in some cases, in red here, the GFR there can be an adaptive repair. In many cases, there isn't a return to baseline GFR, and in fact, there's subsequently the development of CKD and progression of CKD. Here's a large set of studies published now a number of years ago, looking across the board at the risk of CKD after AKI. And you can see many studies bear this out, that after a bout of AKI, there's increased risk of chronic kidney disease. And to be a little bit redundant here from what I've already talked about, the healthy kidney undergoes an insult. There's an effect of cell death. There's macrophages, leukocytes that can be involved. There's vascular compromise. In the case of then many situations, there's DNA damage, increased cell oxidant stress, arrest of the cell cycle, causing increased secretion of profibrotic mediators, parasites that come off the vessels and no longer support the small vessels, and ultimately resulting in a progressive scarring situation where fibroblasts are activated, collagen is produced, fibronectin is produced, and inflammation stays pretty chronic, and you get impaired function. There have been a lot of studies more recently using single cell analysis. Everything I've told you up until this point didn't depend on the single cell analysis, but was confirmed by the single cell analysis. So I won't repeat this, but essentially there was confirmation when we had more specific look at the injury and looked at the transcriptome that you can have adaptive or maladaptive repair signatures, things that I've already talked to you about. Okay, then moving on to therapeutic approaches motivated by the pathobiology. So here's one that's sort of interesting. You may have heard about this already, but this was something which I just want to have an audience response to. Which then, with regard to SGLT2 inhibitors with acute kidney injury, do they predispose to volume depletion and AKI? Have they been shown to reduce the incidence of AKI? So which one is, or which ones are correct? Okay, so that's That's interesting. Okay, so it's interesting. So more, if in reading it, I guess we should have had a third option here for both of them. But so SGLT, so most people said that although it's close to 50-50, predisposed to volume depletion and AKI. It turns out that this is probably predisposed to volume depletion, maybe, but, and I'll show you some data, not so much to AKI when you look at it all. And then the agents have been shown to reduce the incidence of AKI. And I'll show you a paper that came out last week. So this is something we had looked at this more carefully, and this was a meta-analysis looking at large numbers of studies with SGLT2 inhibitors, showing that if anything, the SGLT2 inhibitors group had a lower incidence of AKI than the placebo group in the vast majority of these studies. And why might the SGLT2 inhibitor affect in a positive way? These agents, they might affect metabolism of the proximal tubule, and you could decrease oxygen utilization, increase oxygen tissue delivery, and increase tissue ATP because of the fact that they're going to change the blood flow to the distal. On the other hand, then they can be expected to increase vasoconstriction of the glomerular afferent arteriole and decrease filtration rate. So in some way, you have an offsetting effect potentially on the tubule, potentially, which may be protective, and on the vasculature, which may be harmful. So, but again, looking at the larger studies, there's been no increase, if anything, a decrease in AKI, suggesting that perhaps the right-hand side of this drawing here or scheme may be more relevant. And then, and here's a number of things. There are potential protective mechanisms that at a cellular level that are too many to go into right now. This is a study that just came out at the end of July, and this was giving patients prospectively 4 doses of 10 milligrams of dapagliflozin. Okay, 4 doses, starting the day before elective cardiac surgery. Okay, 97% of the patients were white. This was done in the Netherlands. There was a really quite significant protection against AKI here. Most of the AKI was stage 1, but there was also a statistically significant reduction in stage 2 AKI. So more to follow, but I thought it would be appropriate to just know about that. There's going to be a lot of discussion. This was in one of the JAMA journals. Yeah, JAMA. Yeah. Another study, just so you can be up to date, was a study that came out in the New England Journal in June. Another thing, we haven't talked about acidosis or acid-base balance, but this was a study. There have been a number of papers showing that perhaps acidosis per se is detrimental. So in this context, in hospitals on pressure and patients on pressors, could correcting the acidosis be beneficial with sodium bicarbonate? And this study was a negative study showing that it was not. So again, a recent study that trying to do an intervention that there was some rationale in terms of the pathobiology, but it was negative. Another study, you probably will hear more about dialysis, but this is also going to be a little bit controversial. This is JAMA, so we'll hear more about this. But this was a study from UCSF where conservative dialysis as an intervention was better than conventional thrice weekly dialysis. Dr. Mount may have some strong opinions about this. It wasn't an enormous study, but it was a good group who did this. So you'll hear some more about, and this has to do with the volume management issues. And this is been a back and forth discussion over time. I'm near the end, I believe, right? I've got 37 seconds. Okay. All right. And so we've talked about a number of mechanisms, senescence, vasoactivity, antioxidants. There are a number of trials going on to try to test whether affecting some of these mechanisms will result in protection. And some take-home messages, I won't read through them. We need more ways to identify high-risk patients. We need better biomarkers. We need better animal models. We need better access to human tissue. And with that, I will end, and thank you very much for your attention.
Thank you, Dr. Bonventry. We'll see you back in the Q&A later on.